Hello, my name is Elizabeth Nugent, and in this presentation I will be discussing the challenges and issues surrounding the use and premise of collaborative practice agreements. Moving on to the next slide. The role of the nurse practitioner was created in 1965 by Dr. Loretta Ford and Dr. Henry Silver as a way to increase patients' much-needed access to care and integrate the social, psychological, environmental, and economic situations. In the 1980s, states containing more remote rural areas became some of the first states to allow nurse practitioners to practice independently, granting what is referred to as full practice authority. Today, half of states and U.S. territories fall under the categorization of full practice authority states, meaning their nurse practitioners can practice to the full extent of their education and have prescriptive authority. This also means that half of states do not allow for full practice authority, either reducing or restricting the allowed practice of their nurse practitioners and making it necessary that nurse practitioners enter into collaborative agreements, a contract contributing to barriers of care overall. Next slide. Collaborative practice agreements are written contracts between a physician and nurse practitioner intended to outline tasks a nurse practitioner may perform, as well as the type and amount of supervision or involvement in care delivered by the nurse practitioner. These agreements are utilized in reduced practice states where laws reduce the ability of nurse practitioners to engage in at least one element of nurse practitioner practice. State laws require a collaborative practice agreement with another health provider or limits the setting of one or more elements of nurse practitioner practice. They may also be used in restricted practice states where state laws require career-long supervision, delegation, team management by another health provider or restrict the ability of the nurse practitioner to engage in at least one element of nurse practitioner practice. These contracts are purported to improve quality of care as nurse practitioners are supervised and managed by doctors, but evidence does not support this claim. Even so, half of U.S. states and territories maintain the requirement of some type of collaborative practice agreement in lieu of full practice authority. This decision is left up to each individual state's legislator whether or not nurse practitioners can practice independently, meaning that what nurse practitioners are able or allowed to do varies widely state to state, not for reasons related to their ability, education, training, or safety concerns, but because of political decisions within the states they reside and work. Moving to the next slide. In a study conducted by Martin and Renault, it was found that the median fee to establish a collaborative practice agreement was $500, and the monthly median fee to maintain this agreement was also $500, causing the nurse practitioners in collaborative agreement states to incur higher administrative costs for physicians, nurse practitioners, and indirectly patients' cost of access to medical care. Some would argue that this supervision, while at times costly, increases safety and quality overall through physician supervision, but research has consistently shown that these barriers intended to improve patient safety instead negatively impact cost, access, and quality of care. And Liu et al. Found that patients assigned to nurse practitioners experience similar and comparable outcomes when compared to medical doctors. In addition, reduced and restricted practice states are more closely associated with geographic healthcare disparities, higher chronic disease burden, primary care shortages, higher costs of care, and lower standing on national health rankings. While states with full practice authority instead of collaborative agreements have been found to meet the highest care and quality standards, increase the frequency of routine checkups, and decrease emergency room use. The ability to recruit an adequate workforce is worth considering in the context of today's overall provider shortages, and nurse practitioners in collaborative agreement states are required to find a health provider to work over them, even in rural areas where providers may be harder to come by or recruit, making it more difficult for them to practice in these underserved areas. Even if they were to find a physician to preside over them, if the physician were to retire, the nurse practitioner would be forced to either find another physician in the area to supervise them or relocate altogether, leaving the underserved rural area they had been providing much needed services for short one more provider. On the other hand, nurse practitioners in full practice authority states are able to independently serve any area they feel so inclined, and it has been shown that these states are more likely to have nurse practitioners working in their rural and underserved areas. Moving to the next slide. In order to overcome these challenges, the nurse practitioner community must be proactive in their local governments and state legislatures. Even in states where full practice authority is the law of the land, groups exist that would be motivated to retract these laws if possible. Research and evidence must be gathered and spread throughout the medical and general population, informing communities of the benefits of independent nurse practitioner practice. And for those practitioners in reduced or restricted practice states, lobbying must begin and continue until full practice authority has been acquired. Additionally, nurse practitioners should consider not only lobbying and staying casually involved in their local and state governments, but stepping into political roles, such as running for office, ensuring that the perspective and voice of the nurse practitioner community is heard. The AANP advocates for the consensus model for advanced practice nurses, which seeks to guide state boards on the implementation of APRN licensure, accreditation, certification, and education necessary for APRN practice. If all states were to adopt this model, there would be more clearly defined recognized APRN roles, clarified legal scope of practice, and the severe limiting of APRN practice could potentially come to an end. The National Council of State Boards of Nursing tracks bills related to practice roles for all advanced practice nurses in an attempt to keep anyone interested up to date on the process being made state to state. This is a valuable resource that should be utilized by all nurses currently in an advanced practice role or looking towards a future in advanced practice nursing in order to stay well informed. On our next slide, second to last, in conclusion, collaborative practice agreements are restrictive requirements that only serve to provide barriers to care and do not improve safety and or quality of care, as some claim. Research has shown that the states that have adopted full practice authority for nurse practitioners benefit through improved workforce recruitment and access to care while simultaneously maintaining the highest quality and standards of care. Steps need to continue to be taken towards unifying all states under the consensus model for advanced practice nurses in order to ensure high standards of quality and care nationally and implementation of full practice authority across all U.S. states and territories. Some questions. What type of nurse practitioner practice is allowed in your future states of practice? Full, reduced, restricted? Do any other challenges or benefits come to mind when considering the use of collaborative agreements? Thank you for listening to my presentation.